Nitin Upadhyay sir. We have got esteemed panel of judges for the judgment process. That we have got Dr. Anand Pangarkar sir, Dr. Manish Tote from Amravati, Dr. Abhijit Deshpande from Nagpur, and Dr. Sandeep Mungantiwar from Chandrapur. We have also got coordinator for today's event, this video session. They are Dr. Neha Deshpande and Dr. Rohini Juneja, both from Nagpur. We welcome you all for this session, and I request all the participants to please be ready with their videos as per the sequence. We will be called and asked to share. I request to judges, please enter your marks as you see them live on a paper, and send it to us on private message, either to me or the coordinators, Dr. Neha Deshpande or Dr. Rohini Juneja. So I request our president, Dr. Nitin Upadhyay sir, to please say a few words before we start the session. Nitin sir, you are mute. You are mute, sir. You have to unmute.
Yeah. Okay. Thank you, Dr. Viral. Good afternoon, everyone. I welcome you all to the 45th annual Vidarbha Ophthalmic Society annual conference. This is our the first day, and actually am at the venue. Maybe there will be some disturbances of the signal as I am attending it from my mobile phone. So I welcome all the chairmen, coordinators, and panelists, and the participants. I thank you, every one of them, for participation, and I wish all the best to the participants. And thank you, Dr. Viral, for the scientific program. Thank you very much. Over to you, Dr. Viral.
Thank you, President sir. Now I request our coordinators to please take over. I think we have received a request from Dr. Rekha Khandelwal madam that she is not keeping well, and for some medical reasons she is not able to present her video today. So we are left with 12 videos in the competition, and the prize, as we all know, is the Suta Sutaria, late Dr. Suta Sutaria madam Memorial Prize for the best video. So best of luck to everyone. Over to Dr. Neha Deshpande and Dr. Rohini Juneja for further proceedings.
Thank you, sir. Yeah. Good afternoon, all. At the outset, I would like to thank Dr. Viral Shah sir, Dr. Nitin Upadhyay sir, and a whole team of organizing team of VOS-VRCON. And first, let me introduce you our judges. Our first judge is Dr. Anand Pangarkar sir. He doesn't need any introduction. He is practicing in Nagpur for more than 30 years, and he is also teaching for so many years in Mayo Hospital. Rohini.
I introduce Dr. Abhijit Deshpande. Sir is a phaco-refractive surgeon from Nagpur. He has done his MS from GMC Nagpur and has been practicing here for whole 30 years. Welcome, sir.
I welcome Dr. Manish Tote, sir. He has done his MS from undergraduation as well as post-graduation from GMC Nagpur. He is also cataract and refractive surgeon practicing at Amravati. He is a past president of Amravati Ophthalmological Association, and he has a keen interest in making all videos. Welcome, sir.
And our last panelist is Dr. Sandeep Mungantiwar. Sir has done his DO from GMC Nagpur, DNB from Arvind Eye Hospital, Tirunelveli, and he's of FRCS Glasgow. Sir has worked as consultant at Arvind Eye Hospital for 5 years, and now he's into private practice at Chandrapur since 15 years. Welcome, sir. Let's just begin the most awaited session without wasting any time. Hope the judges are ready with their score sheets. Over to Neha, ma'am.
Sorry. We welcome our first participant, first video presenter.
I am here.
Yeah, Dr. Atul Kadane, sir. Yeah.
I think before we start the proceedings, I think our senior most judge, Dr. Pangarkar, should make the rules clear once again, so for the benefit of all the participants.
Yes. Dr. Pangarkar, sir, please. Dr. Anand, sir. Dr. Tote sir, you can make the rule clear, sir.
Okay. So the rules have been already mentioned that you have a fixed.
Yeah, Dr. Anand
Yeah.
sir is online.
Yeah, sir.
Yeah. Sir, go ahead. Anand sir.
सर अनम्यूट करा स्वतःला.
Sir, you are mute, on mute, Anand sir. Tote sir, you can go ahead, please.
Yeah.
Okay, sir, please.
Yes, sir. Just a reminder that you have only 6 minutes for your video, and 2 minutes will be for the discussion and question answer session. So the distribution of marks is for scientific content, it is 10 marks. Originality of the contents, it is 10 marks. The clarity in the presentation will be 10 marks. And most important thing is within time limit. If you stick to your time limits, you are going to get 10 marks. Because if you overshoot, you are going to lose your marks. And at the same time, at the end of 6 minutes, your presentation will automatically stop. So please be aware of this fact. Don't let your presentation overshoot for above 6 minutes. Best wishes to everybody. May the best video win. Thank you.
Thank you so much, Manish sir. Dr. Neha, please go ahead with the sequence now.
Yes, sir. So Dr. Atul Kadane, our first participant, will present his video now. Dr. Kadane, sir.
Yes, 1 minute.
Start sharing your screen, yes, sir. Yeah.
Good afternoon, everyone. Today in this presentation, I'm going to demonstrate the use of ASI-Anchor, a novel device to manage a case of an subluxated cataract.
Hello, everyone. As you can see, this is a case of a traumatic subluxated cataract, almost 180 degree. I'm marking the area of subluxation with the center of the subluxation. Managing a case of subluxated cataract is a surgical challenge. In this video, I'm going to demonstrate the use of ASI-Anchor, a novel device to manage such type of cataracts. A cataract having subluxation more than 180 degree. The most critical step is to have a perfect CCC, irrespective of whichever method you use to fix the pad. Before CCC, just ensure that there is no vitreous in the anterior chamber. After a clear corneal incision of 2.65 or 2.8 millimeter, you can see that I am inserting a tenoprolene needle 1.5 millimeter away from the center of the subluxation through sclera and bring it out through the main incision with the help of a cannula. Routinely, surgeons use C1 ring to manage such type of cataract, but here in this case, I have used implant called ASI-Anchor. ASI-Anchor is a 2.5 millimeter wide PMMA uniplanar implant. Now, once the tenoprolene needle is out, I am threading it through the central hole in the central rod of the implant. And after this, the tenoprolene needle is again taken back through the sclera at the same site with the help of a 26 number needle. The implant had two lateral arms which are positioned behind the anterior lens capsule, and the central element or the central rod is placed in front of an anterior capsule. Thus, it creates a clip that adheres to a small segment of the anterior capsules. Besides that, the tip of the lateral arms are designed to reach the lens equator and they provide segmental equatorial support, while the anterior rod is sutured to the scleral wall using a non-absorbable suture. Here you can see that the tenoprolene needle is now threaded back into the hub of a 26 number needle. So the implant provides two types of support, anterior capsular support as well as equatorial support. The uniplanar design of the implant facilitates the easy and the smooth insertion through a tight corneal incision. No need to enlarge the incision. However, the surgical skill which is required is the placement of the two lateral arms behind the capsule and the central element in front, as it's a uniplanar implant. So we can take, it requires some sort of intraocular manipulations, creating a space and then managing the lateral arms behind and the central rod in front with the help of a 25 gauge forceps, side port forceps. Now, once this is done, the temporary stay knot is tied and the implant is fixed in the position. After this, phacoemulsification procedure is just like a routine, as if we are doing day in and day out. Removal of cataract is a routine one, as if we are doing on a stable and well-centered lens. This is the biggest advantage of AC anchor over the other methods, because inserting a Sionis ring before removal of an cataract is not easy. You may shear out the rest of the zonules while passing the ring through that unstable bag through the entire circumference of the equator and create more damage. So while here the bag is fixed before removal, so doing a cataract procedure is easy, which is not an easy when you use other method to fix the bag. As there you have to remove the cataract first. Now the implant is now the knot is tied, final suture knot is tied in 4:3:1 fashion, and the knot is buried in the scleral tissue under the conjunctiva. No flaps are required. Dr. Ehud had recommended no flaps to bury the knot, who is the inventor of this implant. Removal of an cortex is a routine procedure, as well as the placement of an intraocular lens in the bag. Once the lens goes in the bag, the remaining the suture knot the sutures are cut flush to the knot, and the remaining threads of the sutures are cut flush to the knot. And after removal of a viscoelastic and sealing of the side port incisions, the case is over. So we can see that AC anchor facilitates a creation of a centered iron capsular bag complex, and therefore helps in an effective visual restoration. Thank you very much.
Thank you very much. Thank you everyone for listening to this my presentation. Thank you. Hello?
Yeah, we can hear you.
I now request the judges to please come up with their queries and questions and discussion part.
I think I finished well before time.
Very well, sir. And very nice presentation. Great voice. Everything was perfect, sir.
Atul,
Yes.
For how many clock hours of just one segment can be used?
I think, see, this, for the subluxation more than 6 o'clock hours, we can go with this, because for a small subluxation of 2 to 3 clock hours, we can use CTR ring. But more than that, we can use this.
Okay.
The advantage is that if you feel that one implant is not sufficient to fix the back, you can use another implant also. So that I have one case also where I use.
Okay. So this.
Have you used it for pseudophakic dislocations?
I didn't find a case, but I have a video, because the inventor person, that Ehud had done it very nicely. And the greatest advantage is that you need a separation of only 2 millimeters, because that is the only place you have to get the implant. While any other method to fix the bag, you have to make it is not possible. The bag is othered, it's long away. Yes. Done. So it's very easy for those cases, but I didn't get a case to operate like that.
Okay. And what's the longest follow-up for your cases?
First case 2018, so it's now 2020, something around 2 years.
Okay.
So at the outset, I'll say excellent presentation, Atul. It was a very nice presentation, crystal clear video, and very good narration.
Thank you, Judge. Thank you, Manish.
Anand sir, you have some questions?
No questions. Very good, very well presented. And I'm very happy that the presentation level was very good.
Thank you.
Exactly. The level of presentation is at par international standard. Very good. Excellent effort, Atul.
Thank you
very much.
I have just one question.
Yes, sir.
While placing the IOL, once the anchor is in place, do you take any precautions so that the haptic doesn't get entangled?
No, sir, because it is the anterior capsular rim which is get clipped with that implant. So I just take a precaution that the haptic should oriented perpendicular to that axis. Means when once it's in the bag, the IOL is in the bag. I see to it in all my 4 cases. Up till now, I did 4 cases. I place the haptic in such a way that it is perpendicular to the part where the implant is fixed.
Exactly. Actually, I was wondering aloud that will it be an advantage if we put a CTR in addition to the AC anchor?
We can put because here there is an additional equatorial support by CTR and anterior capsular support by AC anchor. That will be a double advantage.
Yeah. So Have you tried anything like
Yes,
that?
in my first case, I have to put a CTR also
because that will give a 360 degrees support to the equator all around.
Yes, that is definitely an advantage. You can use it. You can combine it with it. And the greatest advantage is that we can fix it before the cataract removal. I feel that is the greatest advantage, because negotiating any sort of Sionis ring or a CTR in a cataract, that too is a subluxated bag, it's not that easy. We may in that process shear out the remaining zonules also.
Okay, that's all from my side. Anything?
Hi, Atul. Hi, Atul.
Yes, sir.
Did you have to go for vitrectomy in any of your case?
One case.
Like if there is some vitreous prolapse.
Yes, because
Okay.
I actually,
It was the implantation was.
In all cases, I put initially Transilon. In this video, that part was not shown because of the I have to put fit the video. I thought it should be 4 minutes only initially. Then I realized it's 6 minutes, 4 plus 6 plus 2. But in every case, I put a Transilon and see to it if there is vitreous there. In one case, I saw vitreous lip. I did a vitrectomy, and after that, I did all this process. Sir, your voice.
The ASIA's ring, the Sioni ring will be an added advantage because it will distribute the forces all through the bag.
Yeah.
So, because this is a 1-point fixation, I appreciate that implant. It's very good. Its importance lies in the fact that you can do it for even 180 degrees subluxation, where we thought we did not have any choice but to do a lensectomy. So a very nice thing. Good presentation, Atul. Thank you.
Thank you, sir.
So after a great start, we move on to our next presentation by our very own and skilled Dr. Seema Deshmukh.
Rohini, before we go ahead, we have got a query from our audience, Dr. Gajanan Silke,
Okay.
whether this device can be used for pseudo exfoliation also.
What?
Pseudo exfoliation.
Whenever you feel that the bag is, if you think that there is a subluxation of the bag, the reason for subluxation can be traumatic, it can be pseudo exfoliation, anything. You have the basic purpose is to fix the bag, which is more than 4 o'clock hours. The bag is the zonal support is not there, because less than that we can use CTR also. No? Why to use all sort of these fancy instruments?
Okay, thank you, sir.
The important difference between zonular dehiscence with other conditions in pseudo exfoliation is that pseudo exfoliation, it is a progressive one.
Yeah.
So this 1-point fixation may not help. So be careful in pseudo exfoliation.
I don't have experience personally. All 4 cases only I had put it in one in Marfan's, then 2 are my traumatic cases.
Except pseudo exfoliation, the zonular weakness is not progressive.
Yes, excellent point, Anand sir. Actually, that was a very good point to note.
The reason, recently there are one patient with both eyes dislocated, IOLs with its bags. So I was trying to search whether he has pseudo exfoliation, because he has got atraumatic, both eyes dislocated IOLs with bag.
But I can share with you after one video, sir, Pangarkar sir, the whole bag is dangling because of this pseudo exfoliation, and Dr. Ehud had done it very nicely with 2 implants. He fixed the bag, and it was very easy because he has to separate only that 2 millimeter area, nothing to fix the bag. Means I don't find the case. Actually, I told Sawangi Mege that if you have any such case, refer to me. I will do it free of cost because I want to do it.
Yes, it's a good one. If you put 2 implants, then perhaps the bag will stay, even if it is pseudo exfoliation, because the entire structure is dependent on the anchor. Good, yes. Good. Let's go.
Thank you, sir.
Dr. Rohini, yes.
Yes, over to Seema ma'am. Ma'am, you can just start sharing your screen.
So this is our contestant number 2, participant number 2, Dr. Seema Deshmukh.
Hello.
Yes, madam, go ahead. We can see your screen.
Okay.
Enlarge-
Good afternoon, everybody. This is the teaching video for the beginners in the cataract surgery. That is the corneal incisions in the phacoemulsification surgery.
Madam, make it full screen, please. Full screen, please.
Currently, the surgeons prefer the corneal incisions because of its advantage. That is easy access in the anterior chamber or to the cataract, no anesthesia, faster recovery, and excellent visual outcome. So I am presenting here the video of incisions in phaco. Here is the video.
Over the last 2 decades, cataract surgery has evolved from scleral incision to corneal incisions, from retrobulbar anesthesia to topical anesthesia, and from rigid IOLs to injectable IOLs. Currently, most of the surgeons use a corneal incision during the cataract surgery because it allows no anesthesia, faster recovery, enhanced access to the anterior chamber, and excellent visual outcome. Residents now start learning cataract surgery with corneal incisions and then learn the scleral tunnel later in their training program. But we must understand that poorly constructed corneal incisions can start a cascade of problems during the cataract surgery and could put the patient at higher risk of complication. So, we must learn the 3 rules of corneal incisions to help the young surgeons to learn these critical steps of cataract surgery. Rule number 1: stay peripheral. The best corneal phaco incisions are the ones that barely nick the limbal blood vessels. This is because they are peripheral, far away from the visual axis, and produce less astigmatic effect. In addition, the vascular nature allows for more secure and better long-term sealing. Placing the incision at temporal position is more advantageous than placing it superiorly. This is because the temporal limbus is further from the visual axis than the superior limbus, and thus the temporal incision will induce less astigmatism. In most of the situations, a vascular near clear corneal incision is better than an avascular truly clear corneal incision. Rule number 2: make the incision symmetric. The corneal phaco incision can be single plane, dual plane, or even triple plane. But for all these variations, the key principle is to keep the incision symmetric. The roof of the incision and the floor of the incision should be approximately equal in thickness. This allows for more stable incision during the surgery and more secure healing after the surgery. When looking at the incision under the surgical microscope or slit lamp microscope, it should have a rectangular or square configuration. If the incision entrance through the Descemet membrane has a chevron appearance, that is, the floor is likely to thick while the roof is quite thin. So to avoid this mistake, by altering the angle of approach of keratome blade so that the roof and the floor are symmetric. In addition, this angle of approach will allow you to tailor the length of incision to fit your needs. Rule number 3: keep the incision architecture consistent. The incision plays an important role during the phaco by stabilizing the fluidics in the anterior chamber as well as allowing the access to the cataract. The incision width is matched to the phaco tip, irrigation aspiration tip, and the lens injector. For most surgeons, this means an incision of between 2.4 mm to 2.8 mm in width, although this can be even smaller for the certain IOLs and larger for others. The keratome blades that we use are precision made to be desired width, and they will perform well as long as the surgeon makes the incision radial and avoids an oblique entry. This oblique entry with the different in-out path will make the incision wider than the desired, and this will lead to fluid leakage during the cataract surgery, causing an unstable anterior chamber and greater risk of iatrogenic damage to the posterior capsule. The incision should also be of precise tunnel length. Too short of tunnel will provide easy access to the anterior chamber, but it will induce more astigmatism and seal less effectively. The ability to seal at the end of surgery is partially determined by the surface area of the roof and floor of the incision. Many patients desire a refractive correction simultaneously with the cataract surgery. We can correct the large degree of spherical refractive error as well as astigmatism with a proper planning. Temporal phacoincision reduces the ATR astigmatism. Temporal phacoincision will worsen with the rule astigmatism. So, for the patients who desire a refractive outcome at the time of cataract surgery, careful analysis and planning can reduce the pre-existing astigmatism and improves the final visual outcome. Superiorly placed scleral tunnel incision with an internal corneal lip is frequently used by beginning phacosurgeons. It heals quickly, relatively stable, and induces minimal astigmatism. These are femtosecond laser assisted cataract phacoincisions. In conclusion, wound construction is critical in modern cataract surgery because this initial step of procedure serves as the foundation on which rest of the surgical steps are built.
Thank you. This is all about the corneal incisions of cataract surgery. If we follow the rules, the surgery will be safe and easier. Otherwise, it may land up into multiple problems. So for the beginners, it is very important to follow meticulously all these rules of incisions. Thank you.
Indeed, a very educative video, madam. Over to judges for discussion. Manish sir, Pangarkar sir, Abhijit sir, Sandeep sir.
Seema, can you hear me? Am I audible?
Yes, sir.
Very excellent video. I would have loved you to put some of your own experiences and complications made by the juniors in this video. This is an excellent educational video for all, not only beginners, but even people like me who consider themselves as beginners, no matter their age. It's a very good video, but I would have liked, if you want to make your own video, then you have to add this. But I would give you very good marks for making it a very informative one. Perhaps a few points could have been added, but that doesn't take away from the credit. Thank you.
Thank you, sir.
Well, good video at the end. Thank you.
Thank you, sir.
So after this educative video, let's go to videos which is using latest technology. So I invite Dr. Ashish Sapkar for his video presentation. Dr. Ashish.
Thank you for the opportunity. On the outside, I would like to thank VOS. Let me just share my screen.
Hello everyone and welcome to this video. So this slide is just a reminder of what is at stake here. We have to align our toric IOLs to the mark that we made on the cornea. If not, there will be a power loss. So we all know that marking the cornea at 180 is not as easy as it sounds. So there are various fixes to how to exactly get this 180 on the cornea. Nowadays, there are very nice smartphone apps. They basically tell you how bad you were in marking the cornea. And they suggest you a fix. And that fix, if you apply to your Mendes ring while finally marking the position of your toric IOL, that would take you very close to the gold standard, the VRCON or the Callisto, which are the gold standard for marking. So my idea is, instead of the bad mark, the fakes and the mindays, I would directly use a level app to mark the axis perfectly on the cornea. This is how the level app looks. So all you have to do is you have to hold the smartphone in such a way that the Y reads 0, and then you have to rotate your slit lamp beam so that it is in perfect alignment with this bubble that is displayed there. You can see here now it's in perfect alignment. Now this is the view through the slit lamp. I have increased the magnification of the slit lamp so that it is easily possible for the examiner to see how misaligned his beam is as compared to the level app. Now, this is a very simple method to know if the patient's head is tilted on the slit lamp. Just use the horizontal beam of light and focus it on both pupils to see if the head is tilted. If it is not bisecting the pupils equally, it means that there is head tilt while the patient is resting his head on the slit lamp. So after adjusting for the head tilt, you can see there is equal bisection by the beam. And now we can begin our corneal marking. So these are the common mistakes that I did while learning how to mark the cornea for toric IOL. Believe me, I was not using the speculum initially because the cornea became very dry and I was not very fast at marking because my subsequent steps were not very perfect. So as I got perfect in that, I started using the speculum and realized that it is a must to use. The next mistake is that I realized that I was not using an assistant help to maintain the head posture of the patient. It's very difficult for the patient to maintain their head posture while we mark their cornea. And having an assistant who holds their head so that there is no tilts to the head or there are no head movements, it is very useful. Then I was not using additional illumination for corneal marking. Now, this might sound difficult to understand, but I slowly realized that once the slit lamp illumination is made into a fine beam of light, there is no way possible that I would have an excess illumination to know where exactly the beam is or where exactly my marking instrument is with reference to the horizontal beam that I have to mark. So I realized that not using additional illumination makes the process of corneal marking very difficult. The other mistake what I did was I was trying to use a surgical marker pen on the wet cornea. Actually, the cornea had to be dry, but still using the marker pen in a traditional sense sounded very nice to me. But then I realized that navigating a marker pen from the nasal side without disturbing the calibration of the slit lamp was very difficult because the slit lamp was very close to the patient. It's exactly focused on the cornea. So I realized that it is so much easier to use a dialer which is smeared with the surgical ink, and when the cornea is dry, it's much easier to get the mark rather than using a surgical marker pen, and when the cornea is wet, it's more difficult. And finally, there is a calibration error of the slit lamp of about 2 to 3 degrees, which I have easily fixed using the level app. So now this is the slit lamp in action. It's the cornea is a bit dry. There is additional illumination. I'm approaching with my smeared dialer and I'm marking the cornea in the mid-peripheral part. I'm not marking it at the peripheral part. Mid-peripheral part is better. So there is one additional mark there, and on this side, I'm able to get a very long mark which is coinciding with the horizontal slit lamp beam. I don't need any of this that you're seeing on your screen. I just need a level app, and it is free on iOS and Android. There are 5 to 10 different companies which make this app. I also found my slit lamp was off by 2 degrees. The angular tracking precision of this app is 1 degree, which is good news for us because previously we used to rely on slit lamp gradations which have jumps of 5 degrees. Also, intraoperatively, for those who use Mendes ring, that has gradations of 5 degrees or sometimes 10 degrees. So this will be way more accurate and closer to VRCON and Callisto because your final axis will be marked with precision of 1 degree. Post-operative, day 7, you can align your slit lamp beam to the toric IOL holes and then take the beam back on the level app, and the app will give you how misaligned your toric IOL is. This is useful information for any cataract surgeon. I thank you for your attention in watching the video.
Thank you, viewers, for watching the video. I hope I
Dr. Ashish, Dr. Ashish, you are not audible through your mic. I think you speak directly into the computer if possible. Your mic is not audible. External mic is not audible.
Is it audible now?
Yeah, it is audible, but you have to speak a little louder. Yeah.
Okay, thank you, viewers. I hope I have opened up a Pandora's box of questions. I hope the video was audible as well. Over to the judges for the questions.
Yeah.
Okay, judges, I think Dr. Ashish has. Is there any question for Dr. Ashish Sapkar?
Yeah, Dr. Manish sir, please go ahead.
Excellent presentation, Ashish. Have you tried the BRC AccuMark? Because
so what is it a smartphone dependent app?
No, not a smartphone dependent, but it is an attachment which you can put on the slit lamp, and you can confirm your slit lamp calibration on that. It is gravity fed. Okay. It will give you 180, 0-180 axis consistently by gravity.
No, I haven't tried that, but does it give you an oblique axis, or is it just the 180 that
it can give you any axis?
Okay.
All the axis, whatever you want to mark. And the most important thing is with a mobile phone app, again, you are dependent on the stability of your hand. But this device actually fits or attaches to your slit lamp. So you don't have to be dependent on the stability of your hand.
Yes, about that, what I think is that once you have a slit lamp beam and you place your hand on the chin rest, that's the best way to get a very stable hand. And I don't think anyone has a very unstable hand to the certain extent of like few degrees. In my experience, as you can see on my video as well, I was able to track the smartphone and it was changing by 1 degree by each tracking method that I did. So for me, it's quite convenient the way I'm using it. But yes, I haven't tried it, so I can't say anything about the other app that we are talking.
But your other points, the 5 points were excellent. Full appreciation for that.
Thank you, sir. Thank you.
Dr. Sandeep sir, Mungantiwar sir.
Excellent presentation.
Dr. Abhijit sir.
Yeah, really very nice presentation, Ashish. Very nicely explained everything.
Anand sir, any input, sir?
I just wish to know how did he mark with that dialer? Did he dip it in a dye?
Yeah, so the marker pen tip, I have smeared the tip on the dialer, and then I have used the dialer on the cornea.
No, I found that if you wash the eye before that, then the chance of spread of the ink is more.
Yes.
So I prefer marking with a 26 gauge needle so that it leaves a better mark. But otherwise, the contents of Ashish Sapkar's video are excellent. Good application of all the inputs and coming out with a very good solution. Great, Ashish.
Yeah, thank you.
Yes, can we move forward? Can we move on?
The next participant is Dr. Anisha Rathod, contestant number 4. Anisha, you are online. You can start sharing your screen.
The little things. Vital tips for pediatric eye examination. Children are not tiny adults, which is why we spend more time on retinoscopy, which is targeted on lifelong visual learning skills. Hence, before starting the procedure, it is very important that we are ready with our armamentarium, the retinoscope decks, the target, and the retinoscope itself. Please check the illumination before starting the examination. It is essential to establish a rapport with your patient. The examiner and patient should be at the same height and at an arm length distance. You need to keep the child engaged throughout the examination. A happy child is a cooperative child. In an uncooperative child, it becomes a challenge to complete the retinoscopy procedure as the child tends to move away the head. You can try using targets or videos to grab the attention of the child. Hence, make the child sit in the parent's lap with the limbs tucked in the parent's legs. Ask the parent to hold the head of the child with one hand backwards and with manually opening the eyelids, continue doing the retinoscopy of the child. The child rolls up the eyes. Be patient for the eyes to come down. Another examination technique is the cocooning technique. In this technique, we wrap the baby with the help of a large towel or a large blanket, which is comfortable for the child or which the child is used to using in daily life, so as to mobilize the limbs of the child and make the child steady for doing retinoscopy in a supine position. Make sure that the hand which is covering the chest is gentle on the chest and not causing a compression, as it may lead to suffocation. Another way around is to hold the head in between the arms of the child to make the head fix and examine the child for retinoscopy or intraocular pressure measurement. While measuring the intraocular pressure in this position, make sure when the eyes are being opened, not a lot of pressure is put while retracting the eyelids, as it may give you a wrong reading in the intraocular pressures. Sugar pellets are another way which can be used in preterm babies as a pain palliative. A sugar pellet can also be used during ROP laser treatment. A gauze can be used which can be filled with normal sugar, and a pellet can be made with a long string of the pellet coming out of the mouth, and the baby keeps on sucking the sugar pellet and remains immobilized. It can also be used during fundus photography of preterm infants, where the child is given a flying baby position, a speculum is put inside the eyes. The nurse helps in stabilizing the neck and the chin of the baby and helps the baby to get placed on the fundus photograph, aligning the eye near the lens of the camera. The advantage of using a sugar pellet in these babies is that they keep sucking the sugar pellet throughout the procedure, and hence the movements are decreased, thus giving us a stable view during fundus photography. Here you can see the baby sucking the sugar pellet, lying steady and helping in getting a stable fundus photograph.
So keeping up with the good show was this great presentation. Over to judges and panelists for any discussion and questions.
Very informative video, I would say, and because it's really difficult to examine a child without all these other things, which are other tricks which she has shown. Excellent presentation.
Yeah, Sandeep sir. Sandeep sir, any question? Abhijit sir, Manish sir.
A nice presentation. No questions from my side.
A small little tip for the extremely irritable child.
So you want me to give you a tip, or you are going to give me a tip?
No, I am going to give you a tip.
Okay.
The trick is get a multi-dose vial of midazolam and draw 0.25 ml midazolam and ask the parents of the child to open the child's mouth forcibly and keep 2 fingers pressed on both the cheeks. This prevents the swallowing of the midazolam which we are going to put. Just put 0.25 ml midazolam in the child's mouth, wait for 10 minutes, and the child, which would not have allowed you to do anything, would allow you to do this.
Okay, this is something.
Only 0.25 ml multi-dose midazolam. Rider is that the parents should not leave their pressure on the cheeks, so that the child cannot close his mouth and will not swallow that thing for 10 minutes.
Okay. Thank you, sir.
Thank you.
I think
very nice tip for pediatric examination. Now I invite our next presenter, Dr. Shon Chinsore. Dr. Shon, are you ready?
Yes. Can I see my video now?
No, sir. Start sharing your screen. Your screen is not.
Now?
No, sir.
You need to share screen first.
Share your screen first. Yeah, now we can see.
Yes.
See now? This is a case of young patient who is working in a welding workshop.
Just a second. Yeah. Now you can start, sir.
This is a case of young patient who is working in the welding workshop. He is not complaining of anything, only he was complaining that he is having some foreign body sensations. So he was not having any diminution of vision or nothing. This is a dilating picture, but when I saw it under street lamp, I can see only one small white. But I did the B scan where I can see there is a foreign body towards the superior nasal side, and which is which is not even sure that where it is piercing the posterior capsule also. As patient is young, so we decided to remove the foreign body, and we started the procedure as we are doing simply with the this first. You can see here there is a corneal foreign body, there is a corneal opacity, and you can see also there is a anterior capsular tear also, and one white spot that is here, which is shows that there is some foreign body. And as he is working in a welding workshop, I'm sure that this foreign must be a iron burr, which we usually call it as iron burr, and it is very sharp. So I started my surgery after confirming by B scan, where the B scan shows that foreign body is towards the superior nasal side. So here I started with the side port incision with lancer tip. As you can see here, again only I can see the corneal opacity and one small dot of tear, which is anterior capsular tear, and the foreign body is towards the superior nasal side. So how to clarify it? So I started with, as we are doing cataract surgery, I just stained with the Trifine blue. With the air bubble, we can see here nicely and clearly, you can see the anterior capsular tear also, and this is what I clicked, that there must be a three entry through this foreign body. That one is through the cornea, another one is through the anterior capsule, and again it is gone towards the superior nasal side. Now again for me one more question is that whether to go ahead, or because as I am from Buldana, so if it tears towards the posterior capsule, what to do? I started surgery with CCC. This CCC is more important to envelop as towards the anterior capsule tear, because if the tear will extend, that will going to definitely extension towards the periphery, and again the removal of foreign body and also for my surgery will be a troublesome. So here I did enveloping the anterior capsular tear through the CCC, and you can see here I can just clarify, and I did the round capsular CCC, which is round in shape. And now for me it is more easy that I can save the anterior capsule also. Now how to remove the foreign body, that is iron burr, that is also very simply. I started with the Uttarata forceps with the side port incision. I just go behind towards the anterior capsule. This is and just pull the foreign body in the center. As the foreign body is sharpened both the side, it may damage to the endothelial also. And can you see here that foreign body is more than 1.2 millimeter, because it is not coming so easily through the side port incision. So I just tried with the Uttarata forceps and I removed. You can see just by gentle handling, I remove that foreign body, and the foreign body you can see it is outside. Now next procedure is, even though I can just do the bimanual eye and I can remove all the cortical matter, as the patient is young, so there is no hardness in the nucleus. So but the thing is that what next, as you can see here the foreign body again. So with the crescent keratome and side port incision, as here I have to use bimanual eye. But before that, I just did the hydrodelineation. I had not done more dissection because there may be a chances of posterior capsular tear, and that may lead to a hazardous in further. So with small hydrodelineation, I did it, and with the help of bimanual IA, with the help of bimanual IA, I removed it very nicely. Now I am very safe and happy that there is no posterior capsular tear or anything. After that, I put my lens and the surgery is over. Thank you very much.
Very nice presentation, Dr. Sean. Now this presentation is open for discussion. Any questions from our judges? Manish sir, Pangarkar sir.
Sean, I think that intact posterior capsule.
Sir.
Am I audible?
Yes, sir. Please.
I've shown, I mean, the surgery part, very good. Video part, very good. All that I have to do is just tell a few mistakes which I may have committed and improved upon. First thing is, your B scan will also tell you whether there is a posterior capsular tear. Especially if some more time elapses. Then second thing is, anterior segment OCT is very helpful. We can apply the same logic as is applied in the case of polar cataracts, posterior polar cataracts. The role of OCT in posterior polar cataracts to know whether there is capsular dehiscence. And third thing is, see, whenever there is the foreign body size is a little more than your entry incision, you have to align it along its long axis so that it can come out through that incision. You have done it, but you didn't use these words. That's all. You did exactly the same thing. It was coming in Adava position, so to say in Marathi. You made it bha. But good presentation, and I liked your surgical skills. Good job.
Thank you, sir. Thank you.
Excellent presentation, Sean.
Thank you, Manish.
Nice job.
Nice presentation. How do you explain the position of foreign body with respect to the anterior capsular tear?
Sir, that is what, because one thing is that that patient is not complaining of anything. He didn't even complain that he had any history of foreign body because he's a welding worker. He's used to all these things. After full dilatation under slit lamp, then only I can see that then some white spot is there, and then only I realized that with the confirmation of B scan. Even I did the OCT also, sir. But that OptoView doesn't give that much the position and all. So we did B scan, and with the
OCT is to find out the integrity of the posterior capsule. Nothing wrong with that. See,
right,
you
sir,
cannot
right.
have the latest OCT every time. Doesn't
Right,
matter.
sir. Right, sir. Right.
Just I'm just giving a suggestion. First thing, and second thing, this welding business has not resulted in this. What has happened is in the workshop, he must have helped somebody try to break some Loha piece.
Right,
It's a chiseled one.
And his vision is
Second thing is look, as you have rightly done, at the evidence.
Right,
there is no reason why a young man should have cataract.
Right, sir. Right.
First thing, please three points which is when you join, give you a track of the foreign body. And the most important thing is it did not give any pain to that patient because this foreign body was so small, it pierced and went in, and that's all. The wound healed. It must have given him a discomfort on that day, but they ignore it. So that's why there are no symptoms. But these three markings that in forming a tract definitely should raise the suspicion of a foreign body. But good clinical acumen on your part to have first suspected it, and good surgical skills to remove.
Sean, just one question. What was the vision pre-operatively of the patient?
6 by 6.
So how did you convince him for a surgery?
Yeah, that is a big issue because I had shown it on B scan. Then only he realized. On B scan, I showed it to him, and then only he realized. Otherwise, the vision is 6 by 6. 6 by 6.
Great secret, you should say Buldana secret.
he's a lucky patient to have not to have cataract and to have a good doctor for him.
Thank you, sir.
I hope everyone is glued to their laptops or mobiles as we are just halfway of the session. And now I call upon the very accomplished Dr. Praveen Vevare with his presentation. Over to you, Dr. Praveen.
Thank you, Dr. Rohini. I'm going to share my screen. This 26-year-old male presented to us for the cosmetic improvement with a complicated mature cataract in a blind eye. Doing a cataract surgery in this eye would have caused a lot of intraocular complications. This patient was having a total retinal detachment, ectropy on UV, and the angle neovascularization. Even if you take a cataract in this patient, the chance of having a white reflex because of total retinal detachment is always there. So we posted this patient for the intracorneal tattooing. The surgery began with taking an initial incision of around 250
It's 4 o'clock.
and using a blade to make a corneal pocket. Initially, we separated the corneal lamellae with the help of knife, followed by the corneal lamellar separator, which we use in a case of corneal lamellar surgeries. A blunt dissection in a slow manner is needed here as the patient was not having a very adequate intraocular pressure. A circular corneal pocket made all over the unsightly lenticular opacity. The care is taken to cover the opacity all around and make it a circular one. The candle soot is collected with the help of 2 burning candles and the steel pot. This is a very easy method and you get ample of soot. The soot is then collected with the help of a tissue paper and is then used for the intrastromal. The soot is then carefully placed inside the corneal pocket, which we made already, and is sprayed evenly all around with the help of iris repositor. An ample amount of soot is used so that it should not faint with the time. As you can see here, the soot sprayed evenly in the corneal pocket is very effective in hiding the unsightly lenticular opacity. Doing this extraocular surgery in a blind eye with lot of intraocular issues have avoided many intraocular complications like hyphema, risk of having a white reflex after surgery. The corneal pocket or the corneal flap is then closed with a 10-0 interrupted suture so that the soot remains in the corneal pocket and doesn't fade with the time. This is a very simple surgery and it helped tremendously to improve the appearance of a young patient. After closing the corneal lip with the help of 10-0 suture, the excess of soot then is washed away with the help of balanced salt solution. And this is the post-op photograph of the same eye, and the patient is very happy. Thank you for watching.
As you very rightly said, sir, it was a very simple surgery for a doctor, but probably for the patient, it would have been a very gratifying appearance, very gratifying experience. So over to the judges and panelists.
Excellent video, Praveen. Very nicely presented, well in time, and really appreciate your quality of video. Just one thought occurring to my mind. Will this patient develop something like a phacotoxic or phacolytic glaucoma in future? And how are you planning to manage that?
Actually, this patient was having the membranous sort of cataract, and the patient was having a total retinal detachment. There was some amount of ectropy on UV, but the pressure was normal. And this guy was of marriageable age. He was planning to undergo and planning to have a marriage after some time. So I thought I will try this, and even if the patient develops some sort of complications afterward, then we can manage accordingly. But this was the easiest procedure to hide his opacity at this moment of time.
Agreed, but won't the visibility be a problem if you want to manage something at a later date?
See, this is a totally blind eye, no PLI. So what would have been happened? At least I think only thing which can happen is a glaucoma, which can be a painful thing. For that, cyclocravir can be needed, can be done. We are not planning to do any intraocular surgery in future.
Excellent.
And what about the repeatability of this process? Can we repeat it again if the soot fades?
Whenever we apply any pigment like a soot or a ink or platinum or gold chloride in the pocket, then that durability is very, very high. It lasts for many, many years. Actually, this is the patient which I did just few months back, maybe 1 year back. So I don't have any first-hand experience for how long it will last. But I think it should last for years together. And even if it fades away, then we can repeat the procedure.
Repeat.
Yeah.
A good trick to get rid of that cosmetic problem.
Right.
Just a few things.
Yeah.
The neovascularization of the angle, rather iris and angle, and a total retinal detachment means it is a very old retinal detachment, mostly inoperable. That's why that neovascularization occurs. And these patients will have partly absorbed cataractous lenses. And when you try to operate them, they are generally membranous, but they give you an unsightly appearance.
Right.
The only debate to my mind is whether a cosmetic iris colored contact lens would have been an easier option. But this is definitely permanent type and less expensive to the patient and no recurrent expenditure. So good, very good. Praveen, you did a good job. Thank you.
Thank you.
Any other questions?
Praveen, any instance having been used in the literature?
Yes, sir. There are a lot of cases which has been there in the literature, but there are different methods too. Many people apply the ink, the tattoo ink, with the help of the tattoo machine.
Right.
We also have a tattoo machine that gives it penetrates the ink into the superficial stroma and then gives tattooing. But
I am aware of that. I am asking you, how did you get the idea of using soot? That's all.
Actually, sir, this is the advantage of Wednesday meeting, and we discuss a lot of things in that meeting. And me and Pankaj was discussing how to do things like that. So he has some experience of doing the intra pocket tattooing. So he just told me that we can do like this, and I have read in the literature also. So there are few cases which are mentioned in the literature, and but very few. Most of the most of the surgeons are doing basically by the tattoo machine rather than the intrastromal ink. Or
extra academic question: can this Wednesday meeting be there on Saturday when I close?
Most welcome, sir. You are most welcome. Anytime, any day, any time of the month.
Okay. So should we call upon the next speaker, Dr. Samir Gade? Dr. Samir, are you there?
Yes, ma'am. Just sharing my screen. Good afternoon, everyone. This is a fast forward of a pterium surgery where I have used blood as a mechanism for the graft. No glue was used, neither any sutures were taken. The whole point of sharing this video was that the economics of the surgery can be brought down without using the sutures and dye, any kind of glue. And this surgery can be offered to patients at a very less cost, as most of the patients that we see nowadays who turn up at pterygium are not of a very paying category. So the cost of surgery can be brought down. Here the pterygium has been removed with small pterygium rexus. camera went wrong here. So removing the tenons below the pterygium. The graft is being taken from the superior aspect. The tenons and the conjunctiva are separated. And the graft is inverted and placed in the place. Any blood clots already formed are removed from that place. It's held in place together for 2 to 3 minutes. And the case is closed. So a short video. Usually these grafts don't move the next day. By the next day, the complete healing has occurred and the patient is very happy cosmetically. Thank you for watching.
Samir,
Short and sweet video about the commonest problem in ophthalmology. Over to the judges for the question.
Samir, do you really think 2 or 3 minutes of keeping that graft or 2 or 3 minutes time is sufficient, or you need to have it more than 5 or 6 minutes?
So I do a BTCT of patients before pre-op, and accordingly I decide the time of placing the graft before closing the surgery.
And do you patch the eye?
Yes, sir. I patch the eye after closing with the proper. So the next day, I do the dressing the next day. So when the patient comes to the OPD the next day, it's mostly the healing has occurred, and I have never seen up the graft which has displaced.
Do you put BCL?
No, sir, nothing. I just put a moxifloxacin ointment and close the clay.
Samir, which anesthesia do you use?
Sir, this was a peribulbar block.
So, which drugs preferably? Lignocaine or bupivacaine?
Lignocaine, sir. Lignocaine, sir.
So, actually, we want an immobile eye for a longer duration. Wouldn't Sensorcaine will be a better option?
Sensorcaine can be a better option, yes, sir. I have never tried that.
Because I am doing that routinely, and Sensorcaine actually gives the results will definitely improve if you use Sensorcaine instead of Lignocaine.
Yes, thank you so much for the advice, sir.
And one more thing I'd like to suggest, you have not done the ironing of the flap at the end of the surgery. If you do an ironing, your flaps will be much more stable at the end of the surgery.
Right, sir. Right, sir. Thank you so much.
Any more questions?
Why do you patch? Why do you patch, Samir?
Sir, it is important that we don't want the patient usually tends to rub the eye afterwards a little when it becomes irritable, when the effects of the anesthesia drop down. So some patients do rub the eye, so it is better to keep it patched.
So the classical surgical principle that if you keep the two ends opposed and prevent mobility, then they heal by themselves. That's
right, sir.
Judges, shall we move on?
Please.
Yes, definitely.
So next in order, the next presentation in order is by a very talented surgeon and a great teacher, Dr. Rajesh Joshi. Rajesh, sir, are you ready with the presentation?
I think Dr. Rajesh Joshi has some network problems. He will be joining soon, so I think we should take the next one.
So next in order is Dr. Anuradha Rathod. Ma'am, can you share your screen, please? Dr. Anuradha Rathod, ma'am.
Flip the nucleus. Everything visible has a flip side, just like a coin and even cataracts. Flipping the nucleus in phacoemulsification technique after hydrodissection for nucleus removal is a safe management technique for soft cataracts. Watch the nucleus being flipped upside down and emulsified and aspirated easily. Watch the hand movements of the surgeon with the probe and the chopper see the nucleus getting emulsified and aspirated easily. We will repeat this video again in a slow motion for better understanding. After a good hydrodissection, nucleus is prolapsed and emulsified. Using phaco 2, that is vacuum with minimal ultrasound energy, is required. Catch hold of the distal end of the flipped nucleus. Once flipped, the nucleus is farther away from the capsular bag and emulsification is easier with application of little ultrasound energy. To summarize the video again, a grade 2 soft cataract where after hydrodissection the nucleus was flipped, chopped and aspirated with minimal phaco energy.
So it was short, it was educative, and it was sweet. Over to the judges.
Ma'am, can we universalize this process, this technique? Like, can we do it for harder cataracts? You'll have to unmute yourself.
Yes, you can do it for harder cataracts also, but I do other techniques for harder cataract. I prefer this for soft cataracts, mainly to provide margin of safety, you know, because you're away from the posterior capsule and with minimal phaco energy needed.
Is your
Nice,
phaco probe bevel up or bevel down when you attempt that flip maneuver?
No, it was bevel up.
Bevel.
Yes.
Remember having heard this Dr. K.K. Mehta presenting this playback. Very nice presentation, Dr. Anuradha.
Thank you.
The important part is just depends on your sort of approach. If the surgeon feels that the centralmost part, the posterior nuclear curvature is a little more and harder as well. If you emulsify it first, then the job becomes later easy. However, you have to change your tactics when you are taking away the last bit.
Yes.
But otherwise, nice technique.
Thank you, Dr. Pangarkar.
Well presented. So your voice appeared a little different. Sounded rather. Nice one.
So, do we have any more questions?
Dr. Anuradha, could you have told us about the phaco time, which was, if it was needed less in this?
It was effective phaco time was around 1.52 because very minimum phaco energy was needed. It was just nibbling of the nucleus.
Right. Thank you.
After this video, now I think Dr. Rajesh Doshi has joined in.
Yeah.
Dr. Rajesh Doshi, are you here? Yeah. So, our own Dr. Rajesh Doshi now will present the video. Sir, over to you.
Yeah, sure. Are the things visible?
Screen sharing not there.
Visible.
Hello friends. After routine cataract surgeries, post-operative surprises are not uncommon. On post-operative day 1, sometimes I get really annoyed due to post-operative rise of IOP and inflammation caused by retained viscoelastic. If visco is the culprit, can we use only BSS for the surgery? Here we present our technique of viscoelastic. Say a big no, the sticky visco. It is important to keep the anterior chamber maintained throughout the surgery. That is why side pouring is crucial. We prefer MVR blade for side port, which is removed quickly to prevent collapse of anterior chamber. We routinely use rifampicin to stain the anterior capsule. To illustrate how visco behaves during various steps of cataract surgery, we deliberately stained a viscoelastic and we observed it is impossible to remove viscoelastic from the anterior chamber in routine. Continuous irrigation is used through the left-hand side port to maintain the anterior chamber and to stabilize the blood during main port entry by keratom. Here comes the real challenge of viscous deposition, the capsular axis. After stabilizing the globe with left hand, microaxis forceps is used to perform the capsular axis, keeping in mind turbulences and fluid currents of continuous irrigation and irrigation. Hydrodissection is performed during nucleus management. First insert the irrigation on and later replace the chopper. If the vaco emerges useless, direct chop was nucleus was divided into fragments and they were emulsified. For irrigation and aspiration, chopper was removed first. It was replaced by irrigation and then the vaco probe was to the side port, aspiration port was introduced and then the IA was carried out. After the completion of cortical removal, IOL was inserted back under the irrigation. IOL was rotated gently inside the bag with the help of dialer. Start hydrating the ports before removal of irrigation capsule. Friends, let us see how difficult it is to remove viscoelastic completely at the end of the session. Blue flecks seen here are retained viscous. Now I am fully ready to say a big no to the sticky viscous.
Excellent presentation. Now over to the judges for any further questions.
Rajesh sir, excellent video. Just very useful technique, I think, for a high volume surgeon like you. Just one thing I noticed in your video, you said you put an irrigation line and then put your phaco probe. So you have two different irrigation lines separate?
Yeah, I keep
because phaco probe must already be having a own irrigation line.
No, what happens, Manish, whenever you want to exchange irrigation aspiration during cortex aspiration, you have to do the irrigation first.
No. That was not the question, sir. The question is when you introduce the probe inside, enter the eye with the phaco probe, You had an irrigation line, so you used 2 IV bottles separate, one for irrigation line and one for the phaco.
Yeah, no, there are 2 irrigations. One is attached to phaco probe itself. One irrigation is attached to phaco, and other one is for initial rhexis part. And
Yeah, that was what I was wondering about.
Yeah.
Thank you.
Rajesh, Rajesh.
Yes, sir.
I liked your idea of demonstrating the difficulty involved in removing the visco. Actually, when we started doing IOS at that time, the visco used to be a little blue so that we could identify it through the microscopes available then. I shouldn't be asking you this question, but I can't help myself. And the question is, when do you think this technique should be most useful? Just one condition.
Yeah, I think this should be most useful in patients having pediatric cataract or developmental cataract, which are very softer one. You don't have to chop those nuclei. And in these patients, they react postoperatively fast to the viscoelastic.
My mind, it would be very useful and maybe perhaps an imperative in case of toric IOL implantation, where you have to go behind the lens and remove the visco so as to minimize.
Yes,
Sir,
I do agree with you, sir. Otherwise, also toric you can implant under irrigation. So you don't have to inject viscoelastic once you are done with cortical aspiration.
Any cutoff with the grade of the cataract, Dr. Rajesh?
Yes, I don't use this for very hard brown black cataract, small pupil, subluxated lenses. Because sometimes you need viscoelastic. Of course, you should not shy away from using viscoelastic any steps if you find there are difficulties in performing irrigation aspiration or nuclear chopping like that. So in very small pupil, I don't use it. Subluxated cataracts wherein you need endocapsular ring to be implanted, or very small pupil wherein you need to put iris retractor.
And do you have access to specular?
No.
So the comparison cannot be made.
But Manish, you made out a very good point, which was quite emphasized when we started IOS, and that was that our instruments which go inside the anterior chamber are negatively charged, and therefore the endothelial cell loss will be more in absence of visco. However, maybe if you could have done specular, we can prove it or disprove it. But that used to be the classical teaching, and that's why there used to be visco. But this is a good technique for those cases which can be handled easy. Thank you.
Thank you.
Yeah. So any more, we are there with any more questions, or shall we move ahead?
Yeah, we can move ahead.
Yeah, Dr. Rohini, before we move ahead, is Dr. Samir Gade there? Dr. Samir? There is a question from our viewers for Dr. Samir Gade.
Yes, sir.
Yeah. Can your technique be used for dimorphic pterygium?
Sir, I have never tried that.
Okay.
Very frankly.
Fine.
Can judges just answer this question?
Yeah, I have some experience about it. I take a flap from the superior end, a huge flap, in fact. I split it into two. Use the limbal aspect to graft that end of the pterygium where there is a more bigger pterygium in size, and the distal end of that graft I use at the other end. And make sure better not to try sutureless. Always better to use sutures in such cases.
I also have done it in a couple of cases and it works well.
Okay. So we'll move on with our next contestant, Dr. Rohini.
Yes, sir. I think it has been a wonderful session and hope all of you are just engrossed. So now I call upon a very skilled and talented doctor, Dr. Vishakha Jipkate. Madam, are you ready with your presentation? Dr. Vishakha, please share your screen.
Ma'am, is it seen?
Fine, it's fine. You are heard and you are visible. Please go ahead with your presentation. Start your presentation. It's perfect. Start it.
Okay.
Madam, we cannot see the video. You're not playing.
The presentation is not visible on the screen.
Okay. Ma'am, I have started sharing, but it's not coming here.
Just a second, Vishakha. Stop sharing again. Stop sharing. Then start sharing. Stop sharing.
Okay. I've stopped sharing.
No, you are not stopped.
Okay. Stop video. Okay.
Just a second. Now you can start sharing again. And
Okay.
choose the first option you see while
There is a share screen option in below.
6 o'clock.
Yes. So that I have chosen.
Now choose the first option you see there.
Here there is a share on right hand side that I will be click.
Yeah.
And then I will be selecting from my desktop.
Play your video. Yeah, now you can see. Now you can.
Now is it seen?
Yeah. Make it full screen just. Fine, it's fine.
Is it audible, ma'am?
Yeah. Perfect.
Sharing with you all a video of management of traumatic mydriasis of atrophic iris by single pass 4-throw pupilloplasty. Here, AC entry is done and anterior chamber is formed with viscoelastic. The iris is freed from all the sides. Ideally, fluid should be used and AC maintainer should be used so that handling of the sutures is more comfortable. But in this case, we have used viscoelastic. Here we can see a 90 proline suture straight needle is entered inside the anterior chamber from clear cornea. We can either use 10-0 proline or 9-0 proline suture. From the other end, entry in the anterior chamber is done with the help of MVR. Here we will be using a micro forceps which will help in handling of the iris more gently and effectively. This micro forceps catches the iris and helps in stretching it so that passing of the suture is more comfortable and easy. Now the 90 proline suture straight needle has passed inside the iris. All the steps are done very gently because this patient was a phakic young patient and any trauma can cause traumatic cataract. Now from other end, 26 gauge needle is passed in the clear cornea. The microforceps holds the iris, stretches it, and the 26 gauge needle passes through this iris, which is atrophic, very gently, and it passes out. Through railroad technique, the needle of 90 proline passes into the lumen of the 26 gauge needle slowly and this suture is gently pulled out. Now, with the help of a micro forceps, a loop is formed by pulling the suture outside the anterior chamber. Now, we have to pass 4 through inside this loop from outside to inside. This is a very important step. Please focus how the 4 throws are being passed. Now, gently ends of the suture on either side are pulled so that approximation of iris margins is done. By doing this, the pupilloplasty on one side is completed. The ends of the suture are cut with the help of a micro forceps. Now, similarly, the pupilloplasty will be done on the other side. Pupilloplasty is done. At the end of the surgery, we can see a round central pupil. The viscoelastic is aspirated with the help of a Simcoe's cannula, and what we achieve is a central round pupil.
Ma'am, was it clear?
It was perfect, ma'am. It was a very nice presentation, and over to our 4 panelists.
It's really a nice presentation, I would say. The only thing I would like, what I would like to add, I think that viscoelastic really makes it very messy. It's
Yes,
very
it was
difficult
our first
to take
attempt.
four.
Yeah, we realized that. And second thing, we used the AC maintainer. That was the first case we was done, and that was the video which we have attended in AIOS. We have seen there, and from that, just we started our own. That's why I mentioned particularly it should not be used. It was very
Yes.
risky handling that sutures.
And I'll really appreciate that you did it in a phakic patient. That you have to be really very gentle,
Yes.
not going even a millimeter behind. That's really very critical. Nicely done, Sajid.
Actually, nicely done surgery, and really hats off to you. Just your camera needs to be slightly better for a better presentation.
That was our next plan, that it should be better for visualizing.
Because we could not see the 4 throws very clearly.
Yes.
The crux of the surgery is 4 throw.
Our next plan is to buy a Sony camera.
Sir, we are having a talk from the master, Dr. Amar Agrawal himself tomorrow. We will see all the 4 throws very clearly here.
Yes.
Yeah, sure.
So shall we move on? Yeah. So keeping up with the pace, I now call upon our very next presenter, Dr. Abhishek. Dr. Abhishek, are you ready with your presentation, please?
Yes, ma'am. Good afternoon, all panelists, respected panelists. This video is regarding visual rehabilitation in a case of severe visual impairment, post-traumatic corneal tear repair with cataract extraction and PCIOL implantation.
Please start sharing your screen, Abhishek.
Yes, sir. Sir, is my screen visible?
Yeah.
Here is a 60-year-old male patient with history of ocular trauma by wooden splinter. He had full thickness corneal tear with traumatic cataract. Corneal tear was sutured using 10-0 nylon sutures. A superior clear corneal incision was made using 2.8 mm entry keratome. Anterior chamber was filled with viscoelastic to make sure there was no leakage from the sutured corneal wound, and a pre-existing tear in the inferior quadrant of the anterior lens capsule was noted. Using a 26-gauge needle cystitome, hydration between cortex and capsule to separate side port entry was made using 15-degree lens tip. Nucleus was rotated, which seemed quite difficult. Corneal incision was extended using 5.2 mm extension keratome. The soft cortex was aspirated using Simcoe's cannula and a pre-existing posterior capsular rent was identified. The nucleus was delivered using wire vectors and dialer. The posterior capsular rent was confirmed. Any vitreous entering anterior chamber was cut using 1R scissors. IOL was placed in the capsular bag, and the remaining vitreous was cleared from the anterior chamber by cutting with 1Rs and later washed with Simcoe's cannula. Optical iridectomy was done at 12 o'clock position. IOL was rotated to make sure haptics are away from the posterior capsular rent. The wound was hydrated and stay suture was placed. Hello?
Yeah.
Dr. Abhishek, you can continue.
Yes, sir. Yes, ma'am.
So that was the end of your video, Abhishek?
Yes, yes, sir. Yes, sir. Post-operatively on 15-day
Yeah, you can
follow, the patient showed the vision of 618 parts.
Great video. Over to our panelists.
Abhishek, your affiliation, where are you?
Sir, I'm a junior resident in Datta Mege Savangi.
Abhishek, there are a few things we should, I think the opening thing should contain that affiliation, one thing. Second thing is the kind of picture that you are showing, perhaps in my day at least was not shown of yours. One second thing. Third thing is, if ever you want to show a video concerning cataract surgery and management of vitreous, that management of vitreous with manas is strict no-no.
Okay, sir.
It is okay if you do, sometimes the cutter may not be there, sometimes the VR surgeon may not be there, but here it is okay, we will let it go, but outside don't present that manas thing.
Okay, sir, fine. I'll keep that in mind.
And your sutures were not evenly placed while closing the corneal wound. They were quite far apart. The case was managed well, I'm not saying that.
Yes.
Post-op recovery is also good. And then something about the post-op we should mention in order to complete, means you can't just have the thorax and the abdomen being presented. You will have to have a head and a tail to all presentations. In some of these presentations, I have found them lacking. You will have to add that in order to make the story complete.
Okay,
it appears that everybody's focus is on finishing within those 4 minutes, 6 minutes. But let us not forget this. There has to be some background info. There has to be some postscript that the patient improved so much. This and that.
Yes, sir. Okay, sir.
Next time you remember, let us talk privately after this, and I will definitely try and help you if you want.
Yes, sir. Sure.
It is very important.
Yes.
Yes, Dr. Manish sir, any comments?
Yeah, I agree totally with Anand sir. One more thing, in the initial presentation, first presentation, Dr. Atul had made a reference to intracameral triamcinolone. Even that could have been used to manage the vitreous better, I think.
Okay, so fine. So I'll keep that in mind.
Okay. After this now, if there are no more questions, then can we move ahead with the next presentation?
Yes, definitely.
Dr. Aarti, are you there? Dr. Aarti Heda.
Good afternoon, everyone. At the outset, I would like to thank the organizing team for making me part of this interesting session. So, is my screen visible?
Yeah, it's visible.
Yes, Aarti, go ahead.
This video is to comprehensively appraise the state of art with regard to Stevens-Johnson syndrome. The spectrum of the disease defined by Stevens-Johnson syndrome, the more severe toxic epidermal necrolysis and their intermediate characterize a more severe immunologic dermatobullous condition. The estimated annual incidence ranges from 0.4 to 7 cases per million population. While SJS most often represent an idiosyncratic reaction to systemic medications, there are uncommon exceptions and the disorder can be idiopathic. There is widespread keratinocyte death and epidermal necrolysis, resulting in splitting of subepidermal layers with attendant tissue loss at skin and mucosal surfaces. The pattern of clinical signs and symptoms at onset varies somewhat amongst affected patients. The ocular complications can be categorized as related to eyelid, conjunctiva, and cornea. Management of patients with Stevens-Johnson syndrome is usually provided in intensive care units. No specific treatment is noted, therefore, more patients are treated symptomatically. Treatment of acute ocular manifestations usually begins with aggressive lubrication of the ocular surface. As inflammation and cicatricial changes ensue, topical steroids, antibiotics, and mechanical symblepharon lysis can be used. In case of exposure keratopathy, tarsorrhaphy may be required. Maintenance of ocular integrity can be achieved through the use of amniotic membrane grafting, adhesive glues, lamellar grafts, and penetrating keratoplasty, either in the acute phase or in subsequent follow-up care. Coming to the treatment of chronic ocular manifestations, in the case of mild chronic superficial keratopathy, the long-term lubrication may be sufficient. Long-term management frequently involves the treatment of trichiatic lashes or eyelid margin repair for dystichiasis and entropion. If the ocular surface repeatedly fails to heal after multiple surgical interventions, keratoprosthesis may be considered as a last resort. Presenting a case of 22-year-old female with a 14-year-old history of Stevens-Johnson syndrome, who presented to us with a vision of perception of light and keratinization of ocular surfaces in both eyes. Under local anesthesia, keratinized tissue and conjunctiva was excised completely. Planus was removed. Ophthalmic or Capro was selected for the surgery. Donor cornea was stratified and the central 3 mm of cornea was removed. Graft was then sliced over the Capro stem and the back plate was placed. The locking ring was placed. Post cornea was then marked and anterior chamber was entered. Corneal button was excised. Crystalline lens was removed. The assembled Capro was then sutured with 16 10-0 nylon sutures. The conjunctiva was opposed and sutured. Postoperatively, patient regained vision of 6/12. With strict and very vigilant postoperative care, the patient has maintained the same visual acuity over past years.
Thank you. I'm ready to take questions if any.
Great presentation and a very nice surgery. Yes, over to the judges.
Well, very nice surgery, excellently done. I did not hear the post-op follow-up period. How long are you following this?
So 2 years follow-up. I have seen patient for 2 years. I operated this patient when I was in Africa. Last year I moved to India, so I have not seen patient in last 1 year, but I have seen patient for 2 years.
Okay, nicely done, excellent.
Thank you.
Nicely done, Dr. Aarti. I did not understand why such a large part of the video had to cater to the aspects of.
So sorry, sir, I didn't get your question. Why the large part of the video was?
Initial part of the video was devoted to the theoretical aspects.
So I was under the impression that I may be making a presentation of keratoprosthesis followed by for Stevens-Johnson syndrome, followed by my surgical video. So I was really not sure that can I directly jump to my surgical video, because I edited it for just 3 minutes, the surgical video. And I just wanted to give a fair idea about the topic as well.
It could have been shorter. We could have devoted more time to your surgical technique. Very well done surgery. Very good results. The thing is, this is a permanent thing?
Yes, sir. It is permanent.
And that prosthesis outer ring is made of?
So the outer ring is made up of PMMA, and the epithelium grows over it. So within a few days, the inner part is made up of titanium ring, which is helps in locking the device. But the front part is made up of PMMA.
What are the chances of extrusion?
There are very high chances of extrusion. There are high chances of retroprosthetic membrane. So I prefer doing it only in one eye, though patient is very happy because they can see immediately, and not like other corneal surgeries where the recovery is a bit slow. But then keeping in mind that if something comes up in future, want to save one eye. So I have done 4 eyes so far, all these Stevens-Johnson syndrome cases, and I have not seen any major complication as of now.
And how long do you keep them on medications?
So the thing is that we usually follow the post-op regimen as for other corneal surgeries. And the thing is that we have to keep these patients on antibiotics for lifelong because there are chances of secondary infection. So I prefer using 2 different antibiotics and change over a period of 4th month just to prevent the resistance. And since this patient is African patient and they have high chances of getting glaucoma, which is very, very common over there, I do put these patients on anti-glaucoma medications because it is difficult to measure the intraocular pressure. It is not easy to visualize the disc. So that's the reason. But then antibiotics and anti-glaucoma medication, we have to give them.
Nice presentation.
Thank you.
Really excellent presentation, and congratulations for the results. All 4 are doing well. It's a really very satisfying surgery.
Yes, sir. I got to do these cases because I was in Africa and I had no seniors around. Otherwise, I would have referred the case. So I started doing these surgeries at early of my career immediately after fellowship. So it's a bit good for my career that I got a confidence. And I hope I get to do more cases in India.
Responsibility always brings the best out of you. Just tell me, as a note of caution to everyone, if the melting or the rejection occurs, what will happen? What are you scared of?
We are scared of losing that eye completely.
Yes, sir. It's a very high. It's a very high risk.
Yeah.
And in fact, it can result into, in case the thing gets extruded out, there is a very high chance of expulsion of the intraocular contents. That is the only thing against, but otherwise, lovely thing.
It is very important to counsel this patient. It's very important to understand that they have family support for them to come to hospital as and when needed. And the patient education level also matters a lot. Besides that, it is that patient has to be mentally prepared that in future they may have very deadly complication wherein we won't be able to, because this is the last resort. Probably that was the one reason I put all the other treatment modalities available, and then keratoprosthesis is the end stage. Since this patient presented with keratinized tissue and I had no option, and the B scan was normal, vision was CL+, so I decided to take up for the surgery.
That counseling part is so important, because after 2-3 years, if everything is fine, the patient tends to drop down his guard. And that is when the infection strikes, which I realized in a one-eyed patient who had undergone TRAB. Then he had a post-bleb infected bleb endophthalmitis. So one has to be, that patient has to be on guard forever.
Forever, yes. I fully agree to you, sir.
Wow. Very nice presentation, Dr. Heda. And with this, we conclude our session. It's always said that purpose of the presentation can either be a to impress or to inform. I think this time we got not only people informing us, but also many presentation impressed us. Now, I request Dr. Viral Shah sir to conclude the session.
Thank you, Dr. Neha and Dr. Rohini, for excellent coordination. We are able to finish just in time allotted, so it was a very efficiently managed show. I would like to thank our judges, Dr. Anand Pangarkar sir, Dr. Manish Tote, Dr. Abhijit Deshpande sir, and Dr. Sandeep Mungantiwar to join us and to help us in evaluating all these videos. I would also like to acknowledge the presence of our MMC observer, Dr. Sunil Mulchandani, who has joined us on behalf of MMC to observe our VOS-VRCON. So I think we will be now finishing this session, and we'll see you tomorrow for the scientific session as it resumes again at 8 o'clock sharp tomorrow morning. And we have got a scientific feast arranged for all the delegates. So please do tune in tomorrow morning at 8 o'clock. Also, there is a GBM today at 6 p.m. So all the members are supposed to join that GBM online only, virtual. So thank you everyone. I would request the judges to please give the marks and send the mark sheets over to us in our private messages or by email. Thank you.
Thank you, everyone.